Good morning, Dr. Cabrera.
He's wearing the white coat today, too.
Must be at work.
Good morning, everyone.
How you doing, Doc?
I'm doing great, hanging in there.
So it's going to be 3 weeks, right? And you're heading into get your second dose of the Pfizer vaccine.
Yeah, I should be getting it this week. Still kind of debating. I'll be eligible to get it this Thursday. I'm actually on service, on inpatient service right now, which is can be rigorous and it'll continue through Sunday. So I may want to delay just for the chance that I might get which is the most common symptom is fatigue that you might get after the second dose, and so that may last until the next day. And so wouldn't want to have a very hectic schedule and expecting that and the possibility. But again, it is still a small possibility. We're talking about a 4% chance that I might have those symptoms.
So when you say delay, what does that mean? Like you may not take the second dose until a month later, or I mean, can you do that?
2 days.
Oh,
Yeah.
So you can go past the 3 weeks.
Yes, you can. And in fact, there are several areas that are looking at strategies of delaying actually a lot more than that, just so that they can get more people to get at least that initial first shot. And so that's not a common strategy, but it's one that I believe even like the United Kingdom may be one of them that's considering that. And so just to get as many people as they can to get that first vaccine. But that's a different, that again, those decisions depend on the groups that you're considering. Healthcare workers, we don't want to delay them, any more than we have to, because their protection is key, because also to protect their patients and the rest of their coworkers, and obviously themselves and their family.
So there have been studies on this and this delay. Like, what's the maximum amount of time you can hold out before taking a second dose?
We don't know the answer to that question, and experts don't know that yet. But they're still following them. They're still looking into it. The science behind it says that it makes that there shouldn't be any real issue with delaying it in terms of its effectiveness. That it'll be just as effective if you get it after that threshold point, like for the Pfizer vaccine, the 3 weeks. And as long as you get it later, then you should develop the expected immunity after that second dose. The reason why we know that is because there are other vaccines that require a serial doses. For example, hepatitis B, it requires a serial dose. And that second dose can be, for example, you get your first dose, and then that second dose can be 1 or 2 months later. But if you miss that, then you can always catch up. And so we know that the immune system works that way, and it shouldn't be an issue with that second booster.
What are the side effects from the second dose? You mentioned fatigue. I mean, how much of a difference are the side effects between the first dose and the second dose?
Well, when you think about it, when a person gets their first dose, they're being introduced to this foreign object basically for the first time, and the body doesn't really know how to respond to it except to start making its own antibodies and start protecting yourself. Now, when it sees that again, now it's primed. Now you already called in the reserves. The military, so to speak, is primed. And then when it sees that enemy again, in this case, it's just the vaccine, it hits even harder. And then it kind of, it's a big exercise for it. And that's the body responding. So therefore, there could be more symptoms associated with that response.
Okay. Have you heard here on Guam whether or not there have been any serious adverse reactions to the vaccine?
Yeah, and so before I answer that question, which there hasn't been many, is that when we understand about the symptoms that we're having, let's make sure that we're very clear that it's not like you're getting symptoms of COVID. Okay, you're not getting symptoms because of that. Your symptoms is your body's response and making you immune and building up your immunity. That's the response that we're seeing. And so when somebody has a reaction to a vaccine, that's different. Okay, that's them responding to some sort of chemical or some additive that might be in that vaccine itself. And it's been extremely low. And apparently, there's reportedly only about 3 cases so far out of the nearly 5,000 people that we've vaccinated already. And so that's very low. And these weren't anaphylaxis reactions. There was one that was thought to be anaphylaxis. It technically was not. And these were relatively mild to moderate and resolved, shortly thereafter.
Public health, they were saying that staff are being trained on the Moderna vaccine. Is there like a difference with the administration of the Moderna vaccine versus the Pfizer vaccine? Or are there different protocols?
For the most part, not really at all. And it's similar throughout all vaccines. When they're administered, it's pretty much the same principles involved, but it's just getting familiar with it. Familiar with the vial, familiar with the syringes and drawing, and just making sure that those tiny little differences are noted and that you're familiar with it and you're not caught by surprise. For example, the Pfizer vaccine came with its needle and syringe, and that needle and syringe was actually quite advanced for some people who usually use a regular needle and syringe. But this one here, when you press it and you give the vaccine, after you take out the needle, you press it down a little bit further, the needle retracts. And so it doesn't poke anybody afterwards. That's pretty advanced, and that's a safety measure. And so just getting familiar with these type of safety measures or is an example of that. So just, nothing major, but it's more the nuances of that, for example.
There was something that happened last week during the vaccination clinic. I thought it was pretty amazing, just the sheer turnout of the island's Manomco. Those lines were really long. I mean, were you anticipating that many Manomco to go out and go get vaccinated? It was kind of
the one thing we did know for sure is that this was a group that was very motivated, and for very good reason. And so it was a pleasant surprise. And I know there were issues that were reported about especially the first day, some kinks that had to be worked out, but that shouldn't overshadow in any way the major success of these vaccinations, and that they were tremendous. And what they ended up doing, triple what they thought they could do in a day, about that, when the demand rose. What was when you saw the lines, what we didn't really take into account was how fast those lines were moving, actually. So if you walk, you sit down. By the time you sit down, you have to get up and walk again. And so and they were getting them, what they did in the makeshift way of changing the process. Sorry. It ended up being that they're trying to get them as comfortable as possible, get them into the air-conditioned waiting area that was nicely spread out, and then kind of move them through the different stations. And so it was a really well-organized process, and it was very impressive for sure.
Mm-hmm. We do have some questions from our viewers. Can you mix one shot Pfizer and the second shot Moderna?
And so the recommendation now is to not do that, and that everything is being done to avoid that. But we have to know that there may be a situation where that may occur. If somebody's getting their first shot in one location and getting it, let's say they got the first shot in the States and they're getting their booster here after they travel. So there's different nuances where it may happen accidentally, but it's not recommended. In the end, it's thought to believe to still potentially be effective because they're so similar. But it's not like, so if you got a Pfizer shot, then your second shot was a Moderna, we don't come back and give you another Pfizer one.
Well, so that's not gonna happen here.
But everything so far, and we've only been giving out Pfizer vaccines so far, even with the arrivals of all the Moderna vaccines. It's still being Pfizer. We're trying to use up our Pfizer supplies first, obviously, because that takes more logistics in keeping it stored.
Mm-hmm. We have another question. What's the coverage percentage after the second dosage of vaccination?
The coverage, as in if the question is referring to the effectiveness of the vaccine. So right now, what we're seeing is that after you get your first dose, it may be as much as 50% effective, right there. And that's great. And that's about the minimum that the WHO recommends for us to get this pandemic under control. And that's why some areas are just trying to get as many people to get that first vaccine. However, after that second dose, it rises up to as much as 95%. So that's a big jump. So that's why we can't undersell the importance of getting that second dose. But if the main goal is the immediate harm reduction, then in some areas that are being hit very hard right now, like parts of the States and the United Kingdom, then they may look at those different strategies. Thankfully, knock on wood, here on Guam, we're doing okay that we want to kind of go through the process as designed.
Are you part of the VACPP?
Yes, I am, and we did have a meeting last night.
Yeah, can you kind of let us know what happened during the meeting?
Well, there's as we go through the different discussions, we talk about the different groups and we talk about the priorities and what might be unique to Guam and the area. But one thing that I think the group, no matter how much discussion we have about different industries and different parts of services, is that it comes down to saying we need to do as much as we can to reduce the deaths and to reduce the hospitalizations. That should always be our first goal. We've been going through this pandemic for more than 9 months. And so with that being said, we've proven that, at least with our essential services, our essential government services, that we can still operate. And so areas that are saying that we should fortify those, that's true, but it shouldn't come at the expense of trying to protect those that are more vulnerable. So the focus has been shifting to more vulnerable, when we've been trying to vaccinate the vulnerable and fortify our social services, our essential services. But then now I think it's clear that we really are saying we really want to vaccinate the vulnerable more so and get that done more quickly.
We have, what's the timeline on home vaccinations for the homebound Manumco?
That's a very good question. I don't know the answer to that. I know it's in the works for sure, and that they've been working on that. I wish I had a direct update, and perhaps somebody else from public health can give maybe Janela Cabrera can give an update on that. But the key part here is that when we think about the vulnerable population, is that we're thinking about, of course, those with comorbidities, and we're thinking about age as well. And so in trying to balance that, all about comorbidities, how do you prove that? Because if we start saying, it's hard to take a guess here, but probably at least 1/3 of the island has comorbidities. That's a lot of people to vaccinate, and people are gonna, where do they fall in line? One person with just hypertension, which is a comorbidity, versus one person with diabetes. How does that compare with some person who's had a heart attack in the past but doesn't have either of those? So these are questions that we don't want to slow down the process. And so if what seems like it would be a common sense thing is to say, get a order from your doctor, right? Not everybody has a doctor. Yeah. Not everybody, and those who do have doctors don't have, just direct access. They can just call their doctor up and get a prescription. And so that's may not be the most efficient way. It may slow down the process. So that's part of the discussions that we've been having as well. And so in one of the thoughts that have been placed out there is that we go by self-reporting, okay, and that if people self-report their own and they put it in their questionnaire right ahead, review it quickly, see a matches, then get the vaccine. That may be just as good. And that if anybody's gonna fraud that system, I think that's obviously an ethical and a moral no. And what we need to do is to ensure that and have some trust in our community that we want to protect each other and protect ourselves, especially we believe we are vulnerable.
Mm-hmm. Doctor, in this day and age, we've seen that misinformation and disinformation kind of rule quite a bit. Are you still having to battle these, fake stories and the misinformation out there?
I think that's never going to go away, and I think there's always going to be new things that are going to come up. So that's always going to be a challenge. So we just stick to the facts, and we say what we know, and don't make any claims about things that we don't know for sure. That's not supported by evidence and by expert opinions. And so most of what I say is I'm just repeating things that experts are saying, and I do my best to look at the individual data itself and the studies to ensure that I understand it well, and to see why they think it's the right opinions, and that. But the other misinformation, I haven't heard anything new. I'm glad to try and help debunk any right now if you want to go over a couple.
No, I just, you see these things online, and I think a lot of it is just a lack of understanding of some of the basic principles behind this vaccine. And, some people you've seen that they get the first round, they're like, all right, hey, I'm vaccinated, time to go about my business. But, that it as you said, it's only 50% effective. And so people just kind of need to stick to what the doctors are telling them.
And I think, Andy, what another thing that we have to understand is that sometimes disinformation is not on purpose, and it may be people making what would sound like logical deductions about certain things. Like, for example, I got my vaccine. I got even my second dose of the vaccine. Therefore, I don't have to wear a mask anymore, and I don't have to practice the 3 Ws. And so the key part there is that is 100% false. Is that even if you're fully vaccinated, it does not mean that you can't potentially spread coronavirus. You may not get sick from it. You may end up being somebody who would have ended up in the hospital to now just being asymptomatic. That's a real possibility. And because of that, we can't adhere to all the mentioned tried. So that same thought process extends to quarantine. And that just because you have the vaccine doesn't mean you're exempt from quarantine. It's not there is no immunity passport, as of yet. Maybe there will be, someday, but right now that's not the case. Everything else is status quo.
Okay. We do have a question. A question that was never answered. Can a patient get the vaccine even if they have asthma, COPD? COPD, sorry.
COPD. Mm-hmm.
Yeah, COPD.
And so,
I'm not a
yes.
doctor.
Yes, they can. Yes. So COPD being chronic obstructive pulmonary disease, typically seen in smokers, not all the time though, but you see that in long-time smokers, and then asthma being, just about anybody can potentially get asthma. Of course, those are 2 respiratory diseases, and you definitely, once your group is called, and you're going to get vaccinated because you are at higher risk of complications from COVID.
You were a little bit breaking up a little bit. You said yes.
Yes.
Okay.
Definitely. Once you're able to get the vaccine, you should not delay it.
Okay. Do you have any information, or what are you tracking with this reported new strain of COVID?
Well, the one thing we do know is that it's spread. It's likely even than what we're just especially to sequence the strains on a more regular basis. Therefore, we're starting to identify them similar to the ones in the United Kingdom. Now, what we do know about them is that the key part there is that they're more infectious, as in they can spread much more efficiently than the baseline SARS-CoV-2 virus. And so the key part about that is that what we are not seeing so far is that it doesn't necessarily mean that you get more sick from it. Okay, so that's good news right now. The key thing is that we have to also still understand that if it's more infectious, then the likelihood of getting to somebody who's more vulnerable is higher. So ultimately, it will contribute to more hospitalizations and deaths ultimately. But on a per person basis, it's not necessarily going to make you more sick than the baseline. The other question that commonly comes up is, will the vaccines we're using now cover these variants? And right now, all the science and the opinions are pointing to yes, it will cover it, because what's mutated has nothing to do with what is being targeted. And the great thing about the two vaccines that are approved right now, the Moderna and the Pfizer vaccines, them being mRNA vaccines, is that we can tweak them, and we can tweak them so much easier than any other vaccine that's even being developed using different methods. And so if there ever becomes a strain that becomes resistant and escapes the vaccine, so to speak, a tweak may be all that's necessary with a booster, and then that may be enough to take care of that, if that ever becomes a true issue in the future.
You know, well, I was reading, I think this new mutation or new strain, it's in California, Colorado, Florida. How would we know? I mean, if it's on Guam, the current tests that we have, I mean, is it able to detect if it's a new strain?
So right now, no. So we don't do genomic sequencing here on island, and so that would be we would have to send the samples off island to be tested. And so right now, the public health is working with the CDC to arrange that so that we can participate in their strain surveillance program, so to speak. And so the whole country is joining in on that. And it's not just so much so that we can find out if this strain from the United Kingdom or the one down in South Africa, and the other variants, if they end up Guam, it's also that here on Guam, did we develop our own new type of strain? And so it's a general surveillance, and it's a good idea to do it. And what's great now is that it can be done, relatively simple compared to what it was. I think I was still in college when they sequenced the human genome for the first time. And that took many decades, and now we can do it in very, very short order, in just a few hours, sequence a virus and and see what the whole genomic sequence is for that specific virus that infected that particular patient.
You said genomic testing? Okay.
Yes.
Okay.
And so, looking at the DNA for humans, and in this case, the virus is RNA, which is very similar. So it's just sequencing it, basically getting like the source code of it, basically, is the other way of thinking about that.
So these new variants, the mutations, they're still similar enough that they're going to show up on a positive test, but we just wouldn't know that it's the new variant, right?
Correct. It's like saying, can you recognize a dog? But then dogs have different breeds. And so that's the different variations in a species, right? In different dogs, and you can have, from a Chihuahua to a Mastiff, right? And very different, but we can recognize it as being dogs. So that's what the tests do. They still recognize them as being SARS-CoV-2.
Right. So how would you know that this might be a mutated strain that you would be requesting for this genomic testing?
What we would do is we would send samples. As I understand it, we may not necessarily send all our samples, but a sampling of our samples, basically a certain percentage of all the tests of all the positives that we identify. A certain percentage is automatically sent for sequencing, and so it's a surveillance program and trying to see if it's caught. And that's what they've been doing in these other states. Is they've been sending a sample of it. And so they may have identified like 3 in Colorado, but that was just a sample. It's purely from a larger pool.
Okay. So we're currently working on that, right? Public health is. That's what you said.
Yes.
Okay.
Correct. Yes.
Some other questions. Are the vaccinations only a 1-year coverage?
So we don't know that yet. We don't know how long the immunity will last. We hope that it will last at minimum 1 year. And it's already going to be an advantage if it's more than 3 months. because we seem to believe that that's about the extent of what you may get in terms of immunity from just getting the disease naturally. So the vaccine can go beyond that, well beyond that, then that's a big plus, and that may very well be the case because of the how specialized the vaccine.
All right, Doc.
And if it only goes up to a year, it's like a flu shot where we get booster shots a year.
Just real quickly, I want to just follow up on something that I saw in this release. The VA PPC also agreed to prioritize hemodialysis patients at private dialysis clinics. Has that begun already?
Yeah, so what they're doing right now is they're training the hemodialysis staff, the nurses, in how to administer the vaccines. And then right now there's this decision-making process of which one. Now, we said that we want to use up the Pfizer vaccines, for example, but we may just go ahead and jump to the Moderna one for the hemodialysis clinics because it's going to be easier. They can store it there and they can give them as they come in. And that's clearly a population that's very special, and we want to ensure that they're protected. And it may be just, and we have easy access to them because they come, approximately 3 times a week.
I have a standing appointment.
Yeah, and then as well, there's those that do peritoneal dialysis, which is dialysis at home that they can do, and so getting access to these patients is relatively easy compared to the general population. So that's being in the works right now. I'm not sure of the timing of that, but that was reaffirmed last night.
One more question from one of our viewers, Doc. I'll try and read this out. Any experience, Doc, on your patients? Have anyone taken the vaccine, and what is the reaction in percentage that it won't trigger more breathing issues? These things should be mentioned on Facebook because lots of people don't want to take the chance with the vaccine. Also, if you have taken the flu shots. I think this is...
So right now, if you have I think that if I'm understanding the question correctly, it's trying to say what are the odds that you're going to have a breathing issue if you take the vaccine, and then also in relation to if you've had similar symptoms with the flu vaccine, for example. Well, if you've had a reaction to the flu vaccine, a true reaction, then right now we don't believe it's a good idea to get the COVID vaccine until we understand that a little bit better. And especially the person's individual, because everyone's reaction can be very different. Now, the real breathing issue that comes if you have any type of reaction, that's what we call anaphylaxis, and that's where it's a major allergy reaction to a vaccine, similar to if you got somebody who's allergic to bees and they get a bee sting, and then their face may swell up, their throat may swell up. And then that throat swelling up is where all of a sudden air can't pass through anymore, and that's your breathing issue. And that's how some people may die. But then an injection with epinephrine, which is basically adrenaline, that injection can resolve that within seconds. And so that's, but it still requires emergency treatment. And so that's the real key part. That the odds of that occurring is extremely, extremely low. And it's no different than than the common vaccines that we're already getting and that we're very, very familiar with. There is no increased risk with that we know for sure. But one thing that is clear is that they are continuing more trials and looking at those who do have a history of anaphylaxis and trying to do trials with them to see how safely it could be given to them. And that's what I understand that had been reported.
Mm-hmm. You said epinephrine. They are available at the clinics, the vaccination clinics on site?
Yes, it's a standard medication. It's those EpiPens, for example. It's a standard, and if they're in a hospital, we use, we have them in what we call a code card. It's a card is where if somebody where death may be imminent or is in the process of dying, when we call a code blue, for example, all of that's in there. Anything you need to do to try and resuscitate that person, and at the vaccine clinics, those are readily available. It's pretty standard to have, and especially at any clinic.
Okay, and just real quickly, where will this week's vaccination clinic be held if it's not at Ukadu?
It's still to be at Okudu,
Okay,
and I
it's still-
believe they're targeting Thursday, Friday, and Saturday. Right now, there's the community testing going on at GCC that started yesterday and today, and then I guess there won't be anything specific for Wednesday. Then I think they're back at the at vaccination. The key part here is that I want to make one last point, if I can, here, and is that with the focus on vaccines, is that we cannot we cannot underline any more the importance of continued testing, and that testing itself is a strategy in and of itself. And because of that, we have to continue that, and we can't let these numbers drop. Just because our CAR score is low and our new cases identified per day are low, doesn't mean that we can let our foot off the gas. And so we have to continue that. What right now is happening is that there's still a competing resource with the staff that is doing vaccinations and the staff that are doing testing. And testing is nowhere as complicated as giving vaccinations. And so right now in particular, so there is a process that we're trying to get through to demedicalize testing. Because there's a lot of areas throughout the country that don't require any healthcare staff to do the testing. They get trained and then they do that. Right now, for example, the pilot program is GPD. And so there's been personnel from GPD that are being trained to run the antigen testing, and then they can start administering themselves so to do it on serial testing and in the protocol that they have there. There are areas, many universities are using them where they have event planners because they know how to manage people moving, and they're the ones that are in charge of doing these mass testings, for example. And then ultimately they report to the local public health authorities, but the operation part doesn't have to be, medicalized.
All right, thanks a lot, Dr. Cabrera.
Yeah, thank you so much
Thank
for having
you.
me on, and happy to answer any more questions in the future as well.
All right, I'm gonna hold you to that.
All right, take care,
All right.
everyone. Be safe.
Be safe. I mean, we're going to continue and head back into the Zoom room where we have another doctor, Dr. Kelly Neal, who joins us every Tuesday. She's from the American Medical Clinic, and it's our segment.